another of the European Connected Health ecosystem, POPUP ecosystem, which is today targeting the area of matching demand and supply. My name's Andy Bleaton, and I'm the Director for Ecosystems and Membership at the European Connected Health Alliance. I'm going to introduce our speakers in a moment. Just a little bit for those people who joined us today who are unaware of the work that the European Connected Health Alliance do. I'll introduce ourselves now. The European Connected Health Alliance is a member organisation very much targeted towards supporting and providing services for our members. Our members, there's around 750 of them, are in the main companies, policymakers, researchers. We've also got a large group of people who are involved with health and social care in terms of providing health and social care. Patient groups, insurance groups, funders, etc. We have a large network of around 16,500 people who we also make contact with and connect up together. We're a not-for-profit organisation, which is important to understand. And we have a global reach of around 78 countries and about 4.6 billion people. And with that comes our international network of ecosystems, with a roughly around, during normal times, around 150, 160 meetings per year. We're involved with a number of programs that you can see there on your screen in front of you. But our main focus is around connecting up the dots in health and social care. We're very much involved with communications and member support, as well as many, many global events and workshops. And we're very much involved with funding as well. By becoming a member of the European Connected Health Alliance, you can see the benefits in front of you there. Mainly, this is around making connections. It's around accessing our ecosystems, around promoting your organisation and your innovation, and collaborating in some of our programs, our projects, and our events as well. We also think this gives you an ideal opportunity to boost your network, which is important, and never such more important as now. For our members, we provide a set of services, one of which is a collaboration and funding opportunities mail-out as well, which is directly connecting up our members to each other. But in reality, what people know about us in practice is our ecosystem network. Our ecosystem network consists of digital health ecosystems, which are permanent, they're multi-stakeholder, and they're geographically focused. And the idea behind them is that they are all focused around slightly different issues, but they're all targeting the idea of breaking down silos in health and social care, transforming health and social care delivery, but also creating economic opportunity. And now, more than ever, that's more important because of the pandemic. But for now, obviously, people are not able to travel, not able to take part in our ecosystem network. And I'll show you the ecosystem network in a moment. But for now, our ecosystems are online. And we've been building a new program of pop-up ecosystems, as we call them, like the one you're attending today. And I'll come on to that in a minute. You can see here the range of our networks of ecosystems. We've just opened our first ever ecosystem in Latin America, in Argentina. And we've also seen recent openings in Italy, in Lithuania, Norway, and last week, only just last week, we saw the launch of our Quebec ecosystem in Canada, which is exciting for us. This growing network of ecosystems creates an ever greater opportunity to connect together and join forces and collaborate. As I said, we're building a series of pop-up ecosystems. We're just building those now for the next coming months, because we don't think many events will be face-to-face for some time yet. Obviously, these are all going to be changing and would require some changes and flexibility. As you can see, we're planning one to join up and connect up with Australia, which will actually be later than July because of recent events you've seen probably in the news the last couple of days about local lockdowns there. But we're planning ecosystems with India. We're also coming back to the topic of mental health, which many of our ecosystems have found very much both a problem locally in terms of isolation and rise of mental illness, but also in some of the new solutions that have come about because of the remote nature of some of the work we do. We've also got a whole program of new Latin American focused ecosystems, and they'll be coming back on stream in September with a wider network of Latin American ecosystems involving Mexico, Chile, Argentina, hopefully Brazil, and maybe Colombia as well. And then we've got a whole program then for the autumn featuring ecosystems that are geographically focused as well as thematic. So we're looking at ecosystems in Greece. Another one we did last week with Canada, targeting isolation and involving hopefully the Canadian Space Agency as well. And then we're turning back to our local ecosystems for the Highlands and Islands, Lithuania, one of our newer ecosystems, and then we're hoping then to bring our new POPUP, probably virtual ecosystem to Northern Ireland later on in the year. So where does that leave us? In terms of today, we're targeting the area of matching demand and supply. This has been an issue that's bedeviled many governments over the last months as they've sought to both meet the immediate needs of the pandemic, but also meeting the needs in terms of both demands for supplies, equipment, solutions, staff, etc. And today we've got a great panel featuring our ecosystems and our members. We're really pleased that we've brought in and brought back actually our ecosystem from Wales, who started off these pop-up ecosystems by talking about how they were delivering a new service. So we're going to hear from our Welsh ecosystem in a moment. We're really, really pleased to be bringing back to hear how our Malta ecosystem, Malta Health Network ecosystem has been meeting this challenge. And we've also got input from our members, from Better, from Strata Health UK, and from Finland, from our Helsinki ecosystem, medicine as well. So we'll be very pleased to bring those on board. And for now, that's enough for me. I'm going to bring on our first speaker, who is Helen Northmore from our Welsh ecosystem. Helen, if you can turn your camera on. I'll turn my screen off and you can share your screen.
Right, so just gonna, hopefully this will all work. There you go. Thank you for that kind introduction, Andy. And it feels like a lifetime ago, but it was back in March that I originally spoke at one of these pop-up ecosystem events. So if you did hear that, you probably can't remember what we talked about, because it does feel like about 6 months ago rather than 3. So very briefly, just what is the digital health ecosystem Wales? Our focus is around making it easier and faster to adopt digital healthcare technology. We're funded by the Welsh Government, and we're a collaboration between the Life Sciences Hub, which is an innovation accelerator on life sciences, and the NHS Wales Informatics Service, which provides the national digital architecture for IT and informatics and digital services within NHS Wales. You know, you may have seen coverage, lots and lots of coverage about what's been happening in the UK. But for those of you who aren't as excited about devolution as I am, it's worth noting that the NHS Wales is an entirely devolved responsibility. So all the announcements by the UK government don't actually apply in Wales. We have our own government who decide policy and funding for the NHS in Wales. And our focus is around bringing people. We're developing and actually launching next week a developer portal, which will bring together a library of APIs, guidance and toolkits for organisations looking to develop software and products for the NHS Wales market. And we work sort of on projects where we can use that bringing together of people to try and look at quite practical short-term actions to make it easier and faster. And we sit in between NHS, industry and academia. We're publicly funded. It means that we can bring all those audiences together to make it, you know, easier and faster for everyone. So because of that position of the Life Sciences Hub and NHS Wales, we were asked to very early on to be that front door for industry who wanted to talk to the NHS. right back in from early March, industry, and I think the title here, wanted to help. As you can see, we've received over 2,000 offers of support from organisations, companies across the world that were looking at an opportunity to support the NHS in Wales and, you know, hopefully sell their products. They saw this as an opportunity to support, and we were absolutely deluged. We had 150 emails just in the first 3 days when we said that we were appointed by the Welsh Government to be this conduit. And you can see right at the start of the lockdown in the UK, we had nearly 200 people. That was about 170 companies that dialed into a webinar about what could be done. And we were working on behalf of the Welsh Government, 7 health boards that we have, 3 health trusts, NWIS and Public Health Wales, because we felt that our role was to you know, to free up people within the NHS to focus on what they needed to do, because we could be that conduit to do that verification and matching of industry supply versus NHS demand. And actually talking to those organisations, the 3 themes that we went out through an innovation portal, we were looking for infection control products and particularly PPE, medical devices, and then we were but with a less sort of specific requirement around digital solutions. And we were just absolutely overwhelmed by offers of support. We had, I think at one point, 8 people working full time on understanding and verifying the offers of support that were received. And this was just us doing that verification and qualification piece. There were a number of people that worked in shared services who do all the procurement for the NHS in Wales, who were working full-time alongside us. There was probably in excess of 20 people within the Welsh Government, shared services and NHS that were just working on how we manage these offers of support. And so about, I think it was mid-April, because it took us a little while, we had to go through a procurement process, we set up an innovation portal so that we could automate a lot of that work. So we could put out the specifications, exactly what we were looking for, and the requirements that we had, particularly around PPE and infection control, so that we could then automate a lot of these processes and communicate with industry really clearly about what the requirements were and what the process was. And that was hugely successful and did manage to reduce the amount of people that we had working on this, but also have a much clearer communication method with industry. The innovation portal is still live. It's on the Life Sciences Hub website. There are still requests for PPE, infection control, so it is still worth looking at what's doing. We have closed down the digital offers, and we'll get onto that in a moment. So my responsibility in terms of the digital health ecosystem was to manage the inquiries of offers of support. So we had 10% of the offers that came in were digital offers of support. The vast majority were around PPE. And what we saw come in, because there wasn't a specific requirement that we had, was themed, so the offers of support were very much around COVID-19 tracking and tracing and COVID-19 support, lots of remote monitoring solutions that would enable people to be released from hospital or to avoid hospital, particularly around chronic condition management or elderly and frail people and avoiding falls. There were lots of proposals that could make existing systems more efficient. And what I wanted to do is just briefly talk about what that pipeline looks like. Is how do you deal with 2,000 or 200? And so what we did within digital health was we had a panel, a group of people from NHS, Welsh Government, Public Health Wales and others who reviewed all of the offers. So every single offer of support was reviewed by people within NHS, of which 34 were taken forward to look into more detail about whether that was going to meet particular issues that the NHS was facing. And of that 34, 8 offers were taken up. And the reason for that sort of considerable narrowing of the pipeline was in terms of the 2,000, it was nearly 1,600 offers, particularly around PPE, did not include the correct documentation. We went through a due diligence process, or they didn't meet the needs. What we saw was a lot of people saw this as an opportunity But this is still public funding, and so there has to be a due diligence, there has to be complete documentation, it has to meet the standards required, and it has to be a company that can deliver on a contract. And so I think there was a lot of organisations that thought that this, those processes would be completely taken away, and they weren't. But it gives you a sort of perspective that, sort of 4 out of 5 of the offers didn't meet the standards that we needed to. With digital offers in particular, the feedback we had from the NHS was actually their biggest needs were about laptops and people. They were setting up field hospitals. They were dealing with numbers of people being away from work for a number of reasons. So it was, how can I just make sure the lights stay on? Whereas a lot of the offers that we had were people who had products or services that, if they were fully developed, they needed integration support, or quite a lot that weren't fully developed, and said, we've got this thing, we can help you. And so the reason that we had such a small number that were reviewed and then taken up was that there was no capacity within the system to do anything new. And I think that was, and also because NHS Wales is quite different to NHS England, there isn't a system for contracting out a lot of service delivery. A lot of the services that you'd expect in England to be contracted out are delivered by NWIS within Wales. And so it's a very different sort of market and landscape. And it was just that the feedback I had was, I just need to keep the lights on. Can people help us keep the lights on? And that was the overwhelming message. And I think that there was a sort of quite a disconnect between what the situation the NHS in Wales was in and what potentially, particularly companies in the industry, thought that this was an opportunity. And the offers that were taken forward were primarily additional people resources and cybersecurity support. And I think there was a couple of other small projects that have been done, but those were done at the company's cost. They weren't done at NHS cost. So because this is a huge opportunity in terms of transforming the way we do things, and because the offers that we were getting in weren't necessarily meeting undescribed and unmet needs, we worked with the Welsh Government to launch the COVID-19 Digital Solutions Fund, because the Welsh Government were very keen to see if there were opportunities to transform the way we do things now and for the future, working towards the Welsh Government and NHS Wales strategy around digital transformation. So we went to clinicians and informaticians within NHS Wales and said what their sort of key areas of need were. We had 3 themes: remote diagnosis and triage of patients, optimising data collection analysis, and remote citizen support and treatment. And we offered up to £30,000 for up to 8 projects, and actually received 142 entries, because this was open to any UK-based company with a rapid pilot, so 8-week pilot over the summer that would then evaluate the business case for further scale up. And this was looking at existing technologies. Again, feedback we had was, it has to be ready, it has to be up and running, it needs to plug in without any effort. And we're in the position where we're just finalising the project details, and we expect the projects to launch in the next couple of weeks. And we will be providing more information, the story, the journey of the projects on our website, which is digitalhealth.wales. And you can find more information about the projects and their story over the next couple of months. So I think the key things for us were that there was a huge opportunity to do things differently on the NHS side, and there was a real trust and openness to working cross organisation that really meant that we could handle this large number of inquiries and very quickly assess which had the potential to work with the NHS in this period and which didn't. And I personally hope that that doesn't go away, because we have definitely changed the way we do things and try to make things more streamlined, open and transparent. And I think that that's one of the positives that's come out of the last 3 months. Any questions? I know I tend to do this. I tend to talk very quickly. So
thanks for that, Helen. Very, very helpful. Very interesting as well to see that quote you said about it's mostly laptops and people. it's the things you would, I suppose originally you'd kind of think, oh, it's going to be about something else, but yeah, I think it's a sort of telling remark, and I think, you know, certainly with the Digital Solutions Fund, I think that's been a very, very interesting approach, and I think, yeah, I think that's certainly an approach that could be replicated, and the learning from that is very, very valuable. So thanks for that. Thanks for that. And we'll do questions at the end if people have got any questions. I'm very pleased now to introduce what is a very exciting input from Gertrude Buttigieg from our Malta ecosystem. Welcome, Gertrude. Very, 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 very pleased to get Malta involved with this in one of our ecosystems for a very long time, and there's some connections here. These pop-up ecosystems are connecting at the dots, and I think there's obvious links there between our learning from Wales and also from Malta. So, Gertrude, if you're free, I can see you. Wonder if you could share your screen again, and I shall let you go.
Is it sharing properly?
Not yet. If you just press the green button at the bottom again. It was there.
Share screen. Render screen. Share.
Something's happening. Oh, you can see me. And you might, yeah, there you go. Wonderful. Over to you, Gertrude.
Okay. So thank you for this splendid invitation, and I will go on with what I prepared to share with you. I thought of calling it Light a Candle. So by the end, you'll understand why. I'll give you some idea about who we are and what we did. And basically, we're a voluntary organization. We're an umbrella organization. We're a network, and we bring together 40 member organizations, all related to health. And our main aim is to bring organizations together to work on policy and to drive things forward. And we are registered in Malta. We are affiliated with various organizations, mainly the European Patients Forum and European Public Health Alliance, Volunteer Europe, and on an international level, we're very lucky to be part of the International Alliance of Patients Organizations. However, we collaborate with a lot of other entities, both locally and on a European level. We've worked with these organizations on various projects, and it is a very enriching opportunity to collaborate with these entities. Over the past 12 years, which we have been set, we have been involved in various things. One of our first things was the promotion of the European Patients' Rights Day. Later, we got more involved in other things, such as patient safety, World No Tobacco Day, Patient Solidarity Day. We've been involved in a project on European Patients Academy, EUPATI, which is a very interesting concept of empowering patients through learning. And on the bottom left is a photo of the President of Malta, under whom we had the honor of hosting a series of training programs, basically to train organizations on policies, because we always believe that training is a way of empowering people. We were very lucky to run the program between October and February of this year. We had the concluding ceremony on the 28th of February, because dragging it later would have caused us problems. So we were very lucky with that. Well, in November, COVID hit Malta. And in February, the National Health Authorities set up the 111 helpline, and they started testing for cases. And until that point, we're not involved. However, we realized that there was a lot of work which had to be done by public health for the safety of our citizens. And on the 6th of March, we launched a call for volunteers. On the 12th March, the schools closed down, and a big chunk of the Maltese population, at over 100,000 people, were within the vulnerable community, and these were logged in at the same time. Concurrently, our volunteers kept registering, and by the end of March, we had over 500 volunteers registered, but these had to be deployed, so somebody had to do the work in matching the needs and the volunteers. We managed to do that to such an extent that our volunteer pool is still up and running. We are still helping public health with volunteers. And the last count we did was in May, where we had estimated that between March and April, our volunteers had given over 10,000 hours of volunteering, which is no joke. I thought to share with you what we learned from our experience. What were the pluses? Well, obviously, websites and social media were incredible to reach people. We had online registration, so everything was done online. It was very positive that the health authorities entrusted us with the coordination of the volunteers and to give them all the support. We worked closely, as I said, with public health, but also our member organizations, SOS Malta and the Malta Medical Students Association, were incredible at helping out with volunteers. And then we also helped other entities like the Food Aid Program, which was running in Malta. We had people from all walks of life, from students to people who ended unemployed, housewives, any kind you can imagine. People were just ready to work. It seemed that volunteering was giving them a sense of being useful in a time when things were difficult. And they were all willing to learn, willing to do something. It didn't matter if they were a professional, but you asked them just to do some data inputting, they were willing. The minus, the difficulties we encountered. We were inexperienced at managing volunteers, so we had to go on a speed learning process. There was a lot of training and supervision which had to be done with the volunteers, and this was a responsibility on the professionals. We needed to be careful of how much we delegated, especially when there were issues of data protection, as these were dealing with data, dealing with people. Most of the work was office-based due to the data protection issue, and there was a bit of a conflict because people said, how come you want us to come and work from an office when you are promoting people to stay inside? So there was a bit of this issue. We felt that this was an obligation to help the nation and to support our member organizations, since, as I mentioned, most of them are health organizations, and their members fell within the vulnerable group. We had to match the volunteers with the duties required, and this was a very laborious duty, and it had to be done in a very short time span. There were times when I was asked in the evening, can we have 12 people tomorrow morning to help around? So within 2 or 3 hours, I had to phone up many people to see who was willing to come in the following morning. And we had to have people, but we had to be very careful on how to have a complement of people while keeping the place safe due to obviously the nature of the pandemic. What was very interesting is the generosity of the people. I must say, like I could see people literally giving their hearts out. The enthusiasm, this was something which professionals told me. The enthusiasm which the volunteers brought to the team, it helped the professionals to keep at it, to keep going. Somehow people really fitted, they were committed, they bonded in the teams, and that was something incredible. The goodwill of people to work together was incredible. And people, as I said already, were willing to do anything. They were willing to do phone calls. We had even people who were willing to use their own cars to deliver goods, medicines to people who are vulnerable, to people who are quarantined. We had people doing translations because Malta is a very multicultural nation at this point. So we needed to have literature available in the different languages to meet the needs of our society. We've had one of the information booklets which was translated into 25 different languages. So that was really interesting. Well, I thought that to end my presentation, we have to look beyond. We stood up to the occasion, but we really want this to be an experience which we will use to keep strengthening our collaboration with armed organizations, but also with citizens at large. And I thought of closing with a quote I received in a chat, and I'll read it out. The greatest gift you can give someone is your time, your attention, your love, your concern. Because when you give your time, you are giving a priority of your life that you will never get back. And I'm very thankful to all the volunteers who gave up even an hour of their time during this time, because even that hour was precious. And that's why I said it's better to light a candle than to curse the darkness.
What an inspiring presentation from Malta. Thank you, Gertrude, for that. Very, very touching and moving to hear about the response there in Malta, and particularly the response around the use of volunteers. I know that's resonant for many countries who've used and taken to use volunteers to match both demand and supply, and managing volunteers is not an easy thing to do. And I've been involved with many volunteer programs that use volunteers. So very interesting to do in there, and thanks for sharing those lessons, because that's, I think, vital for much of our network of ecosystems. Many of our members and many of our ecosystems have been in countries where they've been against similar calls for volunteers, none such as powerful as that, but certainly here in the UK, for instance, I know we had a large call for volunteers, and record numbers of people volunteered, but it's always important to see how that actually gets managed in terms of helping place demand and supply. And I think, like you said, it's better to light a candle. Yeah, I think that's a very important. And we're really pleased to see Malta back and involved with our ecosystems and our pop-up ecosystems. I'm very pleased now to move along to our next speaker from Strata Health UK, and here, Clint's going to talk about how the pandemic has really helped raise the importance of quality data. So Clint, if you could share your screen.
Thanks, Andy. Really a pleasure to be here again, speaking with you and the rest of the group as well. I'm just going to line up screen sharing here. Please let me know when it comes through.
There you go. It's all yours.
Oh, that's brilliant. Excellent. Today, I wanted to talk a little bit about, obviously, supply and demand during COVID-19 times and beyond. I'm the Chief Exec of Strata Health, Clint Schick, and again, thrilled to be here speaking with you from Southeast England. I've also tied in the anatomy of an intelligent e-referral because I do think that it plays a part in what we're going to talk about today. Firstly, just a brief note on Strata Health. We have a rich history of optimizing health and care transitions, optimizing resources across integrated healthcare systems. We're active in England, obviously, as well as North America, Australia, New Zealand, and parts of the EU as well. We've been around for about 19 years and really operate across health, social care, the third sector in terms of care coordination, and optimizing that across the care continuum. And when we're able to actually win hearts and minds and get people to understand the art of the possible, we win some awards for it, like the Lord Carter Award for Innovation as well. So it certainly can be done. Right, supply and demand. Here's a textbook definition. The supply and demand curve, and when all things go right, we hit a point of equilibrium. Now, this is for illustration purposes only. It's not a scenario really that we're probably ever going to find in a public health system that's delivered free at the point of care, but we can dream. So from a representative standpoint, here's perhaps what an illustration would look like for health and social care based on that same model. And we look at the supply, which is resources in the NHS and the local authorities and third sector. And it's quite capitated, so there's going to be some limits there. You can see sometimes the blue line, you can see it bump up, and that might be spot purchases. So that makes sense. But there are restraints within how much supply. It's just not an infinite amount of a resource that's available. On the demand side, we see it fairly erratic, and that's patients and population health and things that happen, demographics, the impact, pandemics that occur, seasonality, flu season, winter pressure. So it's up and down, and it's hard to understand where it's going to go. So if we look at health and care surpluses, so the blue dot, they're small, unplanned, and kind of unlikely. So you might see them sometimes, but those voids are hopefully managed out, and we try, and if we offer a service in the health and care provision, then we see those services filled. What about shortages? Well, unfortunately, we see shortages often, and we see acute capacity and downstream service pressures. Mental health is one that's key in certainly the UK and globally. Long-term care, nursing homes, and aging population, you name it. We've got challenges there. So what can we do from a supply and a demand standpoint? And how can we help resolve this? And I think as we look at patient need on the one side, and we look at solutions and capacity on the other, we need to try and identify inefficiencies and drive them out. We need to look at a different way to do things. And quite often, we'll find that in a busy environment, there's a comfort zone. And we say, well, we're delivering X, and we believe that it's going to have the impact that we need. On to the next thing. We've ticked that box. Well, here's a time now, and certainly I've heard it in the NHS over the last month or more, that it isn't going to go back to the way it was. We need to embrace this change of a global pandemic to say that we can look at doing things differently. And when you look at matching supply and demand, and I use this slide as an illustration, where you might enter care and the need for care at the top, and then find services at the bottom. It is complex. If there's one thing to take away from this slide, it's complex to get patient need matched and sorted to the resources downstream. And we can strive for equilibrium, but you know what? That's going to be difficult. However, we need to take on the challenge, and part of that is referring patients across a care continuum, and that's the mobilization of getting patients from point A to point B, whatever that might be, and quite often from point A to point B, C, and D because of multi-comorbidities and obviously complex care and packages of care. So we need to look at a systematic plan, because if I use the analogy of a fire and forget, where you're trying to kind of throw spaghetti at the wall and see what sticks, it doesn't often work. Sometimes it does. It's not efficient. And one of the clinicians up in the north recently said, it's a bit like Deal or No Deal, where if we send out a request out into the ether, we hope something happens, and it results in chasing and a lot of frustration and inefficiencies across the sector. And that's no way to run our NHS, certainly after 73 years of it being something that's near and dear to our hearts and key for us. So what do we do? Well, here's kind of 4 steps that might be something to consider. And you can frame these up in your own mind as to how you would achieve these. But certainly in my mind, one of the first things is we need to put the patient at the center. You've heard that before within the NHS or any healthcare integrated system globally. And we need to do that by understanding the directory of service. But please, let's have a directory of service that's dynamic. So not, an old paper that is, once you read it, it's out of date, but something that's live and real. And then we can look at a structured process to allocate resources to need. Structure is good, it manages down variability, and it's important. So I think that if we can do that, we can gain some of those efficiencies that we're after. The second thing would be to compile important and unique patient requirements. So it's not only about clinical need. I mean, that obviously within health and care is key, but you need to look at the level of urgency as well. So is this something that the patient needs addressing ASAP? And if so, maybe they jump the queue to someone else. Or if they can wait, maybe they wait in a queue and actually allow other people to gain access to services. Availability of downstream services, kind of key if you're going to be building an equilibrium across supply and demand. Choice is really important, but sometimes maybe choice ought to be overridden. So if I have an intervention and I want to go to my local GP clinic, and it's an outpatient clinic and it's convenient for me because it's 2 minutes from my house, but I can get to one an hour away, and it's more efficient for the system to deliver that, maybe it should be looked at. Not saying that's the right choice in every instance, but it could be something to consider. And then outbreak and shielding, obviously in COVID times, really important to understand how that influences things. The third thing then is to pull it all together. And you see a puzzle there with NHS, local authority, and third sector, because everybody has a role to play. And when you look at supply, sometimes we just put on our blinders and say, well, it's just the NHS or it's just the local authority. But there's a lot of third sector initiatives out there that quite often say, hey, we have capacity. We want to help people. We need to be in that directory of service, and please include us because we can help. And then the fourth thing is to push or to pull patients into those vacancies or available services. And I'll blow this one up just a little bit for a second to say that these aren't new concepts in healthcare, but if you look at pushing patients into a service, you can get brokerage services that exist today in the NHS, or single points of access, or single points of discharge for that matter, that have a really good understanding of what patient need is, derived from clinicians and assessments, and then understand and match to capacity. And that builds in inefficiencies in kind of linking need and supply and demand. And it allows us to, with those inefficiencies, drive towards placing those hard to place individuals that we define as super stranded within our system. Really important. Pulling patients into vacancies is a little different, and it incentivizes those providers, wherever they are in the continuum, to actually be efficient. And that's probably with service agreements that are put in place by commissioners within the NHS or the local authority. But wow, if you can do that, you can actually say, you need to maintain this level of occupancy within whatever service you're providing. And you'll all of a sudden see these providers pulling patients into their services at the weekend or at the end of the day, or sticking their hand up and saying, we have vacancy, we can help, versus kind of quietly keeping that low because they've been overburdened with patients. So these are some of the things we can do to kind of build that capacity. And wouldn't it be nice if we could kind of wrap that around in a criteria and present it that allows people that are managing single point of access or single point of discharge to mobilize patients and get them into the right place at the right time. And there's a mantra you've heard through the NHS and local authorities as well, is right patient, right place, right time. And we obviously need to earmark that by watching them through that transition of care, whether they're assessed and we understand the capacity and we refer them and there's questions, and then there's exceptions. And we need to be able to manage that efficiently across the system to hit that equilibrium. Within COVID-19 in the last month and a half, Strata identified 3 areas that we could help current clients within the UK and actually globally deal with and manage through the pandemic. And it was around single point of discharge, single point of access, and some diagnostics that were important, again, for efficiencies. And during the last 3 months, we've been able to see progressive clients utilize this and not only embrace new care types to manage COVID-19, but to actually turn off care types like placement into care homes in the interim, but not give away the data. So understand that there was still a demand there and understand what was occurring, but not facilitate that transition because it was unsafe for patients to do so. And so that's pretty exciting for us. And I think that we'll all agree that, one thing is for sure, and as I said before, is we can't go back to the way it was. We can't go back to acute facilities being kind of the front entry point into the system. And certainly for a capacity and for a supply and demand perspective, it can't go on. But if you look at this photo of a very engaged acute center, it can't be for social distancing either. So we need to find a better way to do things. And so I think I'll summarize by saying we need bold, new ways of balancing needs against limited resources. We need to be smart. We need to look at different industries. We need to get outside of our comfort zone. We need to balance supply and demand as best we can. It's time to embrace change. It's time to look through to different things that we can do and learn from different industries and people and successes across the industry. And however good we think our strategy is, to coin a phrase from Winston Churchill, however beautiful the strategy, you should occasionally look at the results. And so I encourage everyone to kind of inflect and understand if there are ways that we can help meet that equilibrium in supply and demand within our NHS and beyond. Thank you.
Thank you very much for that, Clint. I think a very, very interesting view of the other side of what we saw in Wales in terms of how companies actually manage that. And I think a very, very interesting way that you at Strata Health have been working. I know certainly with the hospitals in the UK, certainly in the Northwest as well, and up in Scotland. So very valuable insight, and thank you for that. We're going to now move on and introduce another of the European Connected Health Alliance's members, which is Better in the UK. And I'm really, really pleased to introduce, not for the first time, I'm pleased to say, Thomas Grunick from Better, who's our CEO, who's going to talk about how again, the pandemic elevates the importance of quality data. Over to you, Thomas.
Thank you. Just let me get this. Can you see the screen?
Yes, all systems go.
Thank you. Thomas Gornick, as Blenan said, I'm the founder and CEO of a company called Better, and I'm also the co-chair of the Open EHR Foundation. And today I'd like to talk to you about data. And as EY rightly points out in their report, the crisis has really, really provided what they call a burning platform to accelerate the data agenda. And it's been quite clear for a while that data is a key ingredient of decisions being made in healthcare. But like I said, the COVID situation has really exposed the deficiencies of providing quality data to where it's needed to make these decisions. So just 2 slides on our company. So we are in the healthcare IT space for 30 years. Our systems manage about 22 million patients, and we have about 100 customers in 15 markets. Now, we decided to stop saying that we save lives, which a lot of IT companies do. We actually empower the care teams to do that, and I think that's an important distinction which we realized. So I mentioned we are in the health IT space, so we provide platforms, tools, and applications, and I'll talk about some examples on how they were used to deal with the COVID situation just recently. We run a number of projects. Happy to see the Maltese ecosystem because we are running the EHR project at the Ministry of Health in Malta. Our largest project is the city of Moscow for about 12 million patients, a shared care record. So it's quite obvious that the health IT support of care teams has really failed them in a lot of instances, and there's numerous reports of how bad the situation actually is. And I think, again, the COVID situation, the need for quick response from the IT industry has really elevated some of these deficiencies. So everybody from the NHS to other consultancies are actually talking about the need for a new way to approach health IT, one that is based on open standards, on avoiding or preventing vendor lock-in, modular versus monolith, and actually, again, increasing the importance of data. EY just published a really good report a month ago talking about how the future IT systems in healthcare will be built on a common data layer, which inherently has to be vendor neutral, meaning that the data itself, the format, cannot be proprietary or held by any vendor, as opposed to the situation we have today. So talking about health and care data, we understand that today most applications keep data in their own format. Now, in a time of crisis like COVID, this creates a lot of issues with the right data being very difficult to get, let alone put together into shared care records, which could be used across regions, countries, to answer the challenge of a pandemic. So this problem is well known, and we can see that it's not only in healthcare, but in healthcare, the situation is much worse. Why? Because in healthcare, we need to keep this data for a very long time, ideally for the lifetime of a patient. So what happens when we try to change applications, which we do every 10, 15 years, we have to migrate data from one proprietary format to another, which is a huge cost, or actually a lot of times it's not done, meaning that the next application doesn't have the full data set that was already accumulated for this patient. So the strange thing in healthcare is that we've actually solved this problem for imaging data about 25 years ago, whereas today all the imaging complies with the same standards, meaning that any application can access any modality or any image produced by a modality because of that use of the standard. PDF is a similar concept in documents, but unfortunately the structured data is still kept in the silos of the applications that produced it. And this is our mission, to take this data out of applications and manage it in a data repository, which is not tied to any vendor, meaning that the models are publicly available and free to use. And this is an initiative called OpenEHR, where, as I mentioned in the beginning, I'm also the co-chair. So OpenEHR tries to define data standards for managing structured data and everything connected to that. Its main purpose is to use clinicians to actually design data models which accurately describe certain patient condition around a medical term, like in this case, you see blood pressure. And in terms of what I mentioned in the beginning, the quality, it's ensured because these models are define rules on how to validate this data. They are managed in terms of tie-ins to terminologies like SNOMED and others. But they are also giving the context of the measurement, in this case, blood pressure, as well as the data itself. And this is really important because if you think about it, somebody walks in with a blood pressure of 120/80, but unless you know that this person was under exertion, you actually don't know whether the blood pressure is high or low. It's similar with sleep status and other factors. So the fact that the models allow you to store the context of the measurement with the measurement itself means that the data is stored in a way that is usable when it's passed on to other care settings or applications. But we don't have time to go into details, so I will just finish with some use cases to explain how this is being done. I mentioned our largest customer actually is the city of Moscow. And the city of Moscow, 5-6 years ago, the healthcare system was completely paper-based. In a matter of 5 years, they managed to transform the entire healthcare system with about 1,000 institutions, about 12 million patients, 130,000 users, 50,000 physicians, to a fully electronic record, which is actually storing the data of all the citizens in a single data center. The nice thing here is that while the data is centralized, the applications are provided by several vendors, but they have to release the data to this open format and not lock the customer into their own data format. So this was one of the biggest projects, and it's been running live for the last 3 years. Now you can imagine when COVID struck, it was much easier for them to provide the necessary support to the physicians or care teams, because they already had a consistent care record, fully validated data, which they could use to drive clinical decisions. Another example is a little bit different, is in Germany, where 8 German university hospitals, all the major ones, including Charité and Heidelberg, found that they couldn't share data amongst themselves for research. This was a year before COVID, so they put an infrastructure in place where they have an open platform on site, each one of them, but they allow queries to go across anonymized data for research purposes. So they've normalized their own data from their systems, put it in the same format, and all 8 of them can share this data for research. Now, the interesting thing is when COVID hit, they already had the infrastructure in place, and they were able to launch applications, share these applications across the 8 hospitals, but also share data which allowed them to analyze how the patients are doing, to enable research into what procedures work and what don't. So the third example is in the UK, Somerset NHS Foundation Trust, which used the same concept of using models developed by the community. And here I have to give a shout out to the OpenEHR community, because we are international. Very early on, the Chinese clinicians started developing models, then the Italians, then the Norwegians, Germans, and UK teams got together with, as a community, international community, built high quality clinical data models, which then Somerset was able to use to introduce forms, not only for the research of suspected suspects for COVID, but also the assessment of the care provided in critical care. And they were able to do this in a couple of weeks, going live with the functionality, thus elevating their response to COVID. So in summary, COVID has really increased the need for interoperable quality data. We see this across the board in all geographies. The life cycle of data and applications is so different that there is a clear need to separate the two, and today's applications mostly don't do that. NHSX, Gartner, EY are now openly publishing the need for open architectures with a data-centric approach. And OpenEHR provides clinical models which are free to use, but more importantly, they improve the data quality, and the platforms that run these models enable vendor-neutral lifelong health records. Thank you.
Thank you for that, Tomasz. Very interesting. It's great to see examples as well from 3 different countries to see the value of using open data. So that's very important. And I think certainly the examples from Moscow and Germany in particular, especially as we're just entering the German presidency of the EU, are very valuable. and replicable as well. So thanks for that, and thanks for your input from Better. And it's important to recognise, obviously, Better are involved with many of our ecosystems across our network, and that's immensely valuable, as well as involved with the Digital Health Society, which is one of our.
And in fact, we launched the Slovenian ecosystem 6 years ago.
I was there actually.
Really?
One of my,
You had more hair, I guess.
And also the medicines optimization working group as well. So very, very valuable. And so thanks for that. And now we're going to move over to Finland. Lassie, if you could share your screen. It's going to talk about, again, a different perspective on what the impact was for a supplier from COVID-19 from medicine in Finland, please. One of our Finnish ecosystem members from Helsinki. Over to you. See your screen. Lovely.
Good. Okay. Thank you for the introduction, Andy. My name is Lasse Rousi, and I'm the CEO of Medicine. We belong to the Helsinki Health Capital community, which is part of the European Connected Health Alliance that invited us here. So I'm very happy to be here and very grateful for the opportunity to speak to all of you. Well, this really has been a strange half a year with lots of things happening. And I thought I'd start by telling you about us, about Medicine and what we do, and then followed by the impacts the actual pandemic has had for us. Well, we at Medicine are professionals in connected care. We are a team of 17 people located in Espoo, which is just a few kilometers from Helsinki. But we are not a typical startup. We were founded by a medical doctor over 20 years ago. He was working at the Helsinki University Hospital and really saw a need for connected care solutions and founded Medicine around year 2000. But at that time, the market was not really ready to take on telehealth solutions. So Medicine became a health IT consulting and projects company. We did projects around the globe, from Asia to Europe and the States. And that's what we did for about 15 years. But then, about 5 years back, we saw that now there really is a time for a solution where we put the patient to the center, as it was previously mentioned. Well, we started the development. The product was finished, or not finished, but the first version was out about 2 years back. And then during 2018 and 2019, we gained our first major customers. Those including Linde, a big German corporation, which also delivers remote healthcare services. Nestlé Health, that provides our solution to NHS in UK. We have 2 regions in Denmark as our customers, and in Finland, for example, the Finnish Student Health Organization that provides all the health services to all of the university students in Finland. And then big pharmas like UCB. And we have now signed a population of over 2.5 million end users to our services. And then about the product, our actual product. The product is not based on a single use case or the needs of a specific department in a specific hospital, but it's based on the 15 years of experience we have had with the projects we did in the past. With working in different countries, we saw that there really is a need for a holistic solution that would bring the benefits of connected care to one place. Also, the processes and needs in telehealth are very similar in different countries and in different sectors. Of course, not the same, but still very much alike. So our approach was to build a platform that offered all the tools needed in connected care in one place. So communications like remote video visits, chat messaging, vital signs monitoring, both from connected medical devices as consumer wearables, questionnaires, and so on. And also a solution that has a horizontal reach and that can be used with practically any disease or condition. For example, diabetes or asthma can be configured with the system, as well as now COVID-19. And this is configurable so that these tools can be used in different use cases, in different areas, in different manners. And I guess it's also worth mentioning that although we have a platform that includes all the tools needed in telehealth, we are still or have developed this in a modular way. So we are very open to working with other applications and can only just offer one of the modules we have available. Yes. Well, this year really has been a strange year for us, with lots of terrible things happening and affecting us all. The pandemic hit us hard, especially at the beginning of this year, both on the personal level and then company-wise. But as you all know, the pandemic has not been a bad thing for connected care business. We have actually never seen a potential for growth like this. The pandemic really has been a strong driver towards the use of connected care services in healthcare. I can actually remember the specific moment when I personally realized that something big will happen and will hit us. I was out on an evening run after getting the kids to sleep. And I remember thinking about the effects this pandemic would have to all of us if it would hit Europe. But I also realized that we all working in the digital health really hold the tools that could help and have an effect on helping professionals and actually all of the healthcare to cope with the situation. The negative effects happened rather fast. The healthcare in Finland and in other countries really focused on the clinical work and preparing and treating COVID-19 patients. They did not have time to think about new technologies, and some of our big projects were postponed. I can also remember a call I had with one of the top doctors in Finland, which tells a lot about the situation. I was telling about the connected care services that we could provide, how we could help. But they said that the healthcare is just too busy answering questions from the public by phone, that they really don't have time to think about the use of technology or any of connected care. But the effect the pandemic had on medical professionals, the ones not really working on the COVID-19 specific patients, was probably the biggest driver for the turn to use the connected care tools, at least for us. The doctors, the nurses, and the healthcare was used to seeing patients and treating them the traditional way, face-to-face. And as we were expecting to see connected care tools as a mainstream, maybe within 1 or 2 years, then now almost overnight, professionals were forced to turn to these services. The ones that already had the technology in use benefited a great deal. For example, one of our customers I mentioned, the Student Health Organization, they reported a 20-fold increase in their use of the video appointments during the first month of the pandemic in Finland. I guess at the moment it's about 30-fold. Well, we reacted fast by creating a full software as a service communication service, a service that enables to use the remote visit features of our platform product in a very easy way. We just share user credentials to our customers and they are ready to use the service immediately. This way they get a modern, easy to use solution that can expand to use the full package of connected care services we have when they have time to do so. Also, at the beginning of the pandemic, we started to think about what we could do in a more way. What could we do to help? We do have a platform that can be used for different diseases, as I mentioned. So we did a few internal sprints. We took the material available from WHO and used that to configure our solution for the COVID-19 specific use. We did initial screening, tracing, and risk evaluation with the questionnaires we have. We did automatic follow-up of cases with the communication tools we have. We have appointments by video, visits, and chats. And the remote monitoring we are using to track body temperature and other vital signs for the COVID-19 patients. Again, the questionnaires are also used for follow-up for patients in quarantine or so on. And also a very important feature, sharing correct, specific information and guidance for the patients. We launched our COVID-19 solution in March and have now gained a lot of interest, and this solution is in use, or this technology is in use in one of the hospital districts in Finland and the Institute of Molecular Medicine. And we are now in discussions to expand to Europe. And now, with the first wave of the pandemic easing in Europe, we are focusing on further developing the solution to prepare for the next wave, and then towards a pandemic portal. A pandemic portal that could be used for the next pandemic or even the normal influenzas. And then when we have this in use, I trust that connected care technology really brings a concrete advantage to all of us. And actually that we can't even think about not having connected care tools in our lives, in our daily lives at the time. Okay. So it's interesting half a year behind us, really looking forward for the future. Thank you.
Thank you for that, Massive. Very interesting to see, and also I would say that is very much tied up with what we've seen from other pop-up ecosystems we've had, which have looked at it's the existing digital tools that actually get taken up a lot quicker, and we've seen that quite often with the COVID times as well. So thanks for that, and I think a very, very valuable input from Helsinki, one of our newest ecosystems there in Finland, from the Helsinki Health Capital ecosystem. So a shout out for them for connecting us up with medicine as well. So thank you for that. Just by way of shock and announcement, we've got some time for some questions. I've got a couple lined up already. First question I'd like to ask, just for the panel, if possible, and it's just a generic question, is this is a sort of on a demand and supply. Did you find that you had the right tech available to help you match supply and demand? So I invite any of our panelists to come in with us as a supplier or as a procurer. Did you have the right tech available to help you manage demand and supply?
Andy, it's Clint here. I can maybe pop in and give a perspective. I mean, when we try and match supply and demand with our philosophy, we can't do it alone. So part of the required tech from our stack is interoperability with other tech companies and assessment systems and the like. And I think that's gotten a lot better in the last number of years. I think that, you know, the openness to kind of be interoperable across systems has shifted to doing what's right to get clinicians the right information at the right time. So I'm going to say with hesitation, yes, although we always kind of sometimes we run into bumps along the road as well. You can't integrate with yourself. You have to have a willing participant at the other end. And you know, usually it's pretty good, but not all the time.
So I wanted to come in. So we've been talking within the hub about having an innovation portal since I've been in post about 2 years. And it was always, well, we need a bespoke thing. We need a thing that exactly meets our needs. you know, we'll get a project manager and, you know, we'll look at this, and actually this forced us to go, let's just take an off-the-shelf product and adapt it for our needs. And that's actually worked out for us so well that it's really changed what we think we're going to need. And I think it's just that we get so caught up in it being perfect that actually the current situation just made us go for something good. And it actually was an awful lot easier. And I think that was a key lesson for us, is that, yeah, we focus on perfect when really it's just, does it do the job that you need it to do? Andy, you're on mute.
Good means you can press the mute button, but yes, good is good enough. And it's a lesson I learned many years ago. Gertrude, any input from Malta in terms of the, did you have the right tech?
If we had a problem, we launched our call using Google Forms, which was hacked after 2 weeks. So we had to close it down. And now we're using a paid-up system, which is supported by our partners, Volserve. And it is good to collect the responses, but it is horrible to plan rosters. That was the biggest problem I found, is that technology, when dealing with people, an emergency situation, I still had to come to my paper and writing down my timetables handwritten and then input them in Excel. If I must say, I found Excel as the best tool. I mean, I'm sure people are laughing at me, but it got as simple as that, because I needed a reliable tool which I could use, I could change without the need of learning a new program and a new system. So, well, possibly there is a technology out there, but I didn't have the time to explore and invest in maybe a better tool. But I was very interested in the experience of the e-health projects. Well, wow, people, keep it up.
I think that's an experience that sounds familiar. I used to do rostering in a psychiatric unit years ago, and I used to give the staff the calendar, and they filled it in twice as fast as I could. So that was a lesson I learned many years ago. But existing technology is the reason why we keep using. So thanks for that. It's vital to see. Any input from yourself, Thomas? And you're on mute. Sorry, Thomas.
I mean, we're not really on the healthcare side, but we can see this problem at our customer sites. And I think one speaker mentioned that initially it was obviously the healthcare IT, which is usually the people we speak to, was overwhelmed with the need to make sure that the hospitals are running, and some people working from home and all this, so we couldn't actually speak to them. So it's just coming back now. But you know, somebody told me the other day that the digitalization of healthcare has been sped up by 5 to 7 years because of this pandemic, and we're actually seeing stuff being done now which were almost impossible to do before. Our insurance company just started paying for remote monitoring, which we fought for 5 years, actually as ECH Alliance, in that forum, to make sure that the insurance company would meet the innovations halfway and start paying for them. And it's just happened this month. And all of this is due to the fact that the pandemic has really shown the gaps and the possibilities.
I think that's a message that resonates across all of our pop-ups that we've done. We've seen examples of where people have used the phrase 5 years in 3 days, telemedicine in a week, and all these. And I think it's the big question and the naughty question I shall ask in a minute after I've gone to Lassie.
Oh yeah, well, we're a technology provider, so I have to say yes, we do have the technology.
Yeah.
But well, just what you just said, that we were expecting for a platform solution like ours to take a few years really to adapt, but everything has happened now in a few months, and now we have a technology that really can help different organizations, help the professionals, and we are very, very happy that we can do our part.
Now, another question now, and this is the question that a couple of you have posed yourselves but not answered, is do you think we'll be going back
No.
to how we used to be?
I mean, obviously, you know, there's some issues that maybe were overlooked and some things were simplified, so there will be a need to add some tech, you know, some privacy things, stuff like that. And people, I think even the NHS said that for the time being, you can just use WhatsApp during the pandemic. So obviously, some of these things will go back to other types of something the same, maybe more serious. And as Gertrude before mentioned that they had to switch providers, but going back to what it was before, I don't think so.
Okay.
What we've seen in conversations with health boards and organisations as we're partnering on these pilot projects, the consistent feedback is now is the time to do something different. There's been a real shift in culture and expectation around the rollout of new and more digital services. And I think it's up to us to really capitalise on that and make that the existing and sort of standard culture as opposed to what used to exist. So I don't think there's any going back in that, and you know we'll be doing everything we can to really make the most of that, you know, that big change in attitude while we can.
Mm-hmm. Any other input? Thanks for that, Helen.
Well, plus, you know, I'm staying home a lot more and flying less, and I'm not going to give that up easily.
Yeah. No. And I, at least here in Finland, the pandemic is now slowing quite a lot. Things look rather good, but still the use of these tools, of the connected care tools, is not going down, very much the opposite. They really have, well, everybody has seen the benefit, and now when they have more time, they actually increasing the speed of adapting new technologies and really using them in their everyday life. Okay.
Just a quick question to Gertrude in Malta. Do you think the volunteer network you've got now is, you know, when we always talk about digital health solutions, we always, you know, the providers are, well, how can I scale this up and serve it up in a different setting? That volunteer network you've got now, how do you think you'll be able to use that in a non-COVID way in the future? Because that's a resource, having used volunteer programs in the past myself, that's a resource that won't go away if you use it to.
Well, we have plans to train the volunteers to support in different ways, using their skills, whatever they may be, if they are into IT, if they are into education, to help more a positive health approach in general. Maybe even use technology more, maybe getting some form of support for the patients. We're still exploring. I mean, I think we're slowly coming out of a mass of work. We're trying to catch up, but we do want to hold on to our pool of volunteers because we know that they were very important in the success which Malta achieved in fighting the pandemic, and we want to find ways of how it can be used for the good of society in the coming years, because this is an important resource we do not afford to lose. I raised my hand earlier. I have a bit of a question for the people who are more into the data and the digital. In Malta, we know that over 95% of people are connected. But there is still a question of the digital divide in the countries where they have gone full-fledged digital. How did they reach out to the people who are off the digital radar?
Yeah, that's a good question. I'm just trying to think. I mean, obviously, when we say digital, there's several aspects. One is digital internally inside the healthcare system, reaching out to patients. I would think it's always a combination still, right? it's really hard to do this if not everybody has the capability. But it's very similar to other public services, right? I mean, you have ways of just basically addressing a part of the population that doesn't have access by keeping it the way it was.
Okay.
I don't think there's a big difference in healthcare here.
I think one of the things, looking at the internal digital exclusion, it's also the staff. It's not just the patients. Not everybody is fully on the digital journey. So the Welsh Government have funded organisations, as one called Digital Communities Wales, to work with NHS staff to make sure that everybody's able and willing to use the new tools that come along. And they also do a lot of work with communities and excluded groups. So there's, you know, clear sort of organisation support, and they use digital champions and all sorts of tools and to reach those sort of hard to reach audiences. But it's don't forget the staff. It's not just the patients.
Any input from Nasser or Clint?
I guess on kind of a personal note, I mean, you know, I saw an uptick in care home services that kind of allowed residents to use technology to reach out to family as they were isolated. And my mother's in a nursing home in Canada with dementia, and you know, really we benefited strongly from, you know, again, kind of an uptick in utilization. Now, some of those residents in that facility are, you know, we're quite savvy to begin with, but you know, I think again, there's kind of an uptick with kind of isolation that allows, you know, us to benefit as a society, and kind of again see that shift occur a little bit quicker than it might have. You know, I know when my kids are my age and or you know, even sooner than that, I mean, everybody's going to be completely digital, and it's happening really quickly. So yeah.
Yeah,
Okay.
yeah, I really agree with everybody else that the digital telemedicine really brings a big benefit to a very large group of people. But there are challenges, this being one of them. But still, we can use both the digital services, maybe by the professionals, and then the traditional ones. It should not be a showstopper to take on the digital services.
Thank you for that. Two quick questions. Firstly, a technical question, and secondly, a topic you mentioned, Clint, about having a director of services. I think it was you that mentioned that. How prevalent or realistic is that, or have you found that that's something that's been an aspiration?
It's completely realistic, but it's a hard grind. So, you know, you can have a directory of service, and it can be like a published newspaper where, you know, you go and you scour across a region, whether it's 100,000 people or, you know, our largest integrated region is upwards of almost 8 million. And you can achieve that directory of service in a point in time. And a lot of times that's what occurs. But to have it really effective, it needs to be what I refer to, and I coined this from, you know, one of the clinicians up in the north in the NHS here, dynamic. And that would be that it needs to kind of live and breathe. And the only way to do that is to embed it in workflow. And if you can do that, it kind of takes care of itself. And that's an oversimplification because it's a monster to manage, but hugely beneficial if you can do it.
Okay. On that, thanks for that. And just a final question in terms of a couple of you talked about open platforms and open platforms. Thomas, specifically for you, how having an open platform, has that been an additional benefit for Better, or an open data platform? Have you found that easier during the crisis?
Well, absolutely. I mean, you know, what we're trying to do is actually, you could call it this disruption, right? And then disruptions are facilitated by new needs, and especially these needs becoming front and center. And I think what, for instance, they've learned in Germany is that, you know, they have no culture of sharing data, and actually they have a culture of keeping data where it is. And this doesn't work in a time like this, right? So just like any, you know, delays in putting technology in place have been now overcome. I think it's very similar with these assumptions of no, we want to do our own thing. I mean, this is where the open agenda comes in, because it's really much easier to do if you can agree on keeping things like data formats and not proprietary. And the business reasons which the vendors usually present are then on the other side not accepted by the customers, who actually struggle because of this. So absolutely, I think this is anything that goes across one enterprise into a region or a country inherently must be open, because you'll never agree on a single product for the whole country. But you should be able to agree on a single set of data models, because that's where you are then enabled to pull data together as needed. And God knows we needed it now and during COVID.
Yeah. Thank you for that. Any other input from the panelists at all? Well, with that, I'd like to thank all of you for your contributions. And for the first time, we've had a panel discussion, which has been useful to have, because these things, one of the nice things about Zoom is we realize how 10 minutes presentations just don't happen. But today they have done. So thank you very much for all of your contributions. It's really great to use these pop-up ecosystems to connect the dots between both our ecosystems in Wales and Malta and Finland, and in Slovenia, and also our members across the UK and Finland and Wales and Malta as well. So it's one of the great opportunities. And I think one of the lasting things I should think about from today is the idea of the difference between match and demand and supply. Is back from an old phrase we used to use in health and social care when I started. People used to vote with their feet, and we're now seeing that people are voting with their fingers a lot more by using their tools they've got around them, and I think that's very positive to see. So on that note, I'd like to say thank you very much for your participation and your time and your presentations and your thoughts as well. And that, I'll draw this session to a close. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.